at the National Aging Research Institute. Welcome to our online seminar in Aging program. I would like to begin by acknowledging the traditional owners of the lands on which each of us are meeting today. For me, that is the Wurundjeri Woi Wurrung people. And I would also like to acknowledge the traditional owners of the lands and waters across Australia. I pay my respects to elders past and present, and to all Aboriginal and Torres Strait Islander people, including members of the Stolen Generation. Before I introduce our speaker today, just a little bit of housekeeping. At the conclusion of this talk, we will have an opportunity for some Q&A. If you have any questions, you can submit them through the chat function, which can be opened using the chat tab at the bottom of your screen. And today's seminar is going to be recorded and uploaded onto our website in a couple of days. So if you do want to put your hand up at the end of the talk and ask a question directly, please feel free to do so. But do keep in mind that if you turn your video on, to ask a question, your image will be included in the recording. Today, I'm really excited to be presenting Dr. Dona Jayakody. Donna is the head of Brain and Hearing at the Ear Science Institute, Australia. In addition, she's also a Career Advancement Fellow at the Royal Perth Hospital Research Foundation, an Adjunct Associate Professor at Curtin University, and a Director of the Australian Society for Medical Research. Donna's research has contributed significantly to understanding the broad health impacts of hearing loss, particularly on cognition and mental well-being, and has influenced changes to clinical guidelines and policies nationally and internationally. Today, she will be presenting on the impact of untreated hearing loss on healthy aging, which we're all very excited to hear about, particularly given the link between hearing loss and dementia as well. So a warm welcome to you, Donna, and over to you.
Thank you very much, Bianca. Thank you very much for the introduction, and thank you so much for inviting me to share our work with all of you here today. Before I start my presentation, I'd like to give a bit of introduction about the work that we do at Ear Science Institute Australia. So I started this Australian Cognition and Hearing Loss program in 2015. We have several components to this program. We investigate the impact of hearing loss and hearing loss treatment on cognitive, mental, and psychosocial well-being of hearing impaired old adults. We have done a lot of work on hearing health in Indigenous old adults. We conducted several studies on hearing health and impact of untreated hearing loss on tonal language speakers in China and Singapore. The work we have done led to, we support our clinicians with the clinical assessments and guidelines, especially for supporting people with hearing loss and dementia. And then we convert our research findings into suitable commercially available clinical tools. And so today, what we have done, we published over 60 papers with more than 1,400 citations, which led to more than 14 awards. Presented our work at around 80 conferences. We do this work with a multidisciplinary team from neuroscience to geriatrics, health economics, and data science and aged care. We have 35 local collaborators, 8 national collaborators, and 19 international collaborators. The work we've done led to changes in national and international clinical guidelines, protocols, and policies. To date, we've secured over 7.5 million research findings and industry collaboration to develop these commercial tools. We're really big on sharing our work with the community. And 17 masters in audiology, 9 honors, 4 PhD, and 4 postdoctoral students have contributed to the work that I'm going to share with all of you here today. First of all, when we talk about the healthy aging, when you look at the life expectancy in the world from 1950 to 2023, we can see an overall increase in life expectancy of both males and females. According to the World Health Organization, in 2020, the number of people aged 60 years and older outnumbered children younger than 5 years. Between 2015 and 2050, the proportion of world's population over 60 years will nearly double from 20% to 22%. So if we look at the Australian statistics, 56% of the old adults that are between 65 to 74 years and 31% are between 75 to 84 years. So we can assume that the majority of the clients that we see in our clinical settings are old adults. Hence, it's very important that we find out more about the factors that contribute to healthy aging. So according to World Health Organization's ICOP model, there are 6 components important for healthy aging. Today, I'm going to share our work, how untreated hearing loss impacts the cognitive capacity, psychological capacity, locomotor capacity, and vitality. So hearing loss, it is the second highest cause of disability in the world. Currently, 1 in 6 Australians do have a disabling hearing loss, and that number will increase to 1 in 4 by 2050. In summary, 70% of the adults aged 70 years and above do have a disabling hearing loss. And even if people start realizing that they're struggling to hear, they usually wait about 9 years to seek help. So by the time they get their first hearing aids, they're around 70 years of age. So they really don't realize by waiting for 9 years the impact it's going to have on their well-being. Hearing aid uptake is quite poor. 1 in 3 who benefit them usually use them. So in our clinics, when we see hearing impaired old adults, they could be at risk of several other comorbidities, such as cognitive impairment and dementia, physical frailty, mental distress, social isolation, and loneliness. So it's really, really important for us and our clinicians to have a good understanding of how untreated hearing loss could affect old adults, and also learn to look at the bigger picture. And rather than just focusing on hearing loss. So the first part of this presentation, I'm going to talk about psychosocial well-being. I'm sure all of you know that social isolation means limited relational network and social contacts. Loneliness is this unpleasant feeling you get from the discrepancy between desired and existing social relationships. Both social isolation and loneliness are risk factors for cognitive impairment and dementia. So we wanted to investigate the relationship between hearing loss and psychosocial well-being of old adults. So we went to the community and recruited 202 participants with hearing problems, and we measured did a comprehensive hearing test, measured their social interaction and social support, and also social and emotional loneliness. The results revealed that there was a significant interaction between aging and hearing. So poor social interaction scores were seen for people who are not only older but with poor hearing. Living alone, depression, and stress had a significant impact on intense level of social loneliness. We came across a very interesting finding, that is, as the severity of hearing loss increases, we saw an increase in emotional loneliness levels. So if we look into it this little bit in detail, aging reduces the number of social contacts and affects the number of social activities. So hearing loss imposes more demands on the communicating partners. For example, they will have to speak slowly, exaggerate the articulatory movements, sometimes move closer to the listener, keep on having to repeat conversations over and over again. And that leads to frustration, or sometimes the communicating partners get really annoyed. So as a result, they tend to make less contact with people with hearing loss. Recently, I interviewed couples who, as part of one of my research studies, in which I asked about the impact of hearing loss on the person with the hearing loss and their partner. So the partners mentioned how frustrating it is to have a conversation with the person with the hearing loss, and how that affected their relationships. And then when they were treated with hearing aids, and the people with hearing loss, they gained their confidence back. They wanted to go out, interact with people socially, and they could really have a really good, meaningful communication, and that led to improvement in their relationships. So these are the things sometimes we kind of tend to realize. It's just things don't really matter, but these small things have a huge impact on quality of life and well-being. So the next study, we looked at the impact of hearing loss on mental distress. First, we did a systematic review. We realized that hearing loss has 1.47 increased odds of depression. Mild hearing loss had a 32% increased risk for anxiety, and as the severity of hearing loss increased, moderate hearing loss increased about 59% of led to increased risk for anxiety. So again, we went to the community and recruited people with hearing loss and looked at the association between untreated hearing loss and mental health distress. They all completed a hearing assessment and depression, anxiety, and stress assessment. We saw that untreated hearing loss was significantly associated with depression, anxiety, stress scores. And as the severity of hearing loss increased, both in the speech range and also in the high frequency range, the depression, anxiety scores also increased. So then after that, the next logical question for us to ask was, what happens if we treat the hearing loss? So there are many ways of treating hearing loss. One, with hearing aids. Those who with mild to moderate levels of hearing loss benefit from hearing aids. Those who have very severe levels of hearing aids, if they meet the medical criteria, they benefit from cochlear implants. The first part, we look at the hearing aid users. We follow them up for 12 months. I have summarized their results here. So we have depression, anxiety, and stress scores over time. In blue, I've marked the results of the normal hearing listeners. In gray, hearing aid users. In yellow, hearing loss group. So if we look at the results, we can see that over time, normal hearing listeners had just stable depression, anxiety, stress scores. They were quite low. And over time, those with hearing loss had very high levels of depression, anxiety, and stress scores. However, hearing aid users, their scores were pretty stable over time. Then we looked at the impact of cochlear implants on mental health over time. So when we tested their hearing, speech perception in quiet, speech perception in noise, and also depression, anxiety, and stress. Again, we have depression, anxiety, and stress scores here. In blue, I have marked the results of normal hearing listeners. In yellow, people with hearing loss who didn't get a treatment. In gray, I have marked the results of cochlear implant group. Here we came across a very interesting finding that after receiving the cochlear implant, after 12 months of receiving the cochlear implant, we saw very high levels of depression and anxiety scores in the cochlear implant recipients. So, what we did was we went back and had a conversation with the clinicians. Clinicians were unaware that their clients had high levels of depression and anxiety, and even the these research participants, cochlear implant recipients, were not aware of their depression and anxiety levels. So in cochlear implant assessment test battery, usually there are a lot of tests are being conducted, medical tests, speech and hearing tests, but most of the implant centers don't look at the mental well-being or the cognitive assessments. So if someone has high levels of depression scores, that would affect the rehabilitation that's conducted after receiving a cochlear implant and overall outcome of the cochlear implant surgery. So this was a really interesting finding, and then we made recommendations to the implant center to consider including a mental health assessment and cognitive assessment as part of the cochlear implant candidacy test battery. So if you look at the hearing loss and mental and psychosocial well-being of hearing impaired people, first and foremost, it's really important to manage the hearing loss using whatever the device that are suitable for their hearing loss, either hearables, hearing aids, or hearing implants. Next, it's also important to train the communication partners or significant others on supporting this person with a hearing loss socially. So that could help them and help their confidence and help them have a meaningful conversation. And also it's important to train audiologists so that they can, if they see their clients have got some mental distress, so they can provide appropriate referrals. And not everyone gets the support they need in this journey. So we wanted to see whether peer support groups can help reduce social isolation and loneliness. This is a study we have just completed. So as much as, we used to think that hearing aids and cochlear implants and those hearable devices are the only solution for people with hearing loss, but we've come to understand that they need additional support. So we investigated the importance of peer support for improving well-being of these hearing impaired old adults. So we went back to the community, had a community conversation, and asked the community members, if we were to create an online community, what sort of social media we would like, you want us to use. And they suggested Facebook, because most of the people of that age group seems to be using Facebook. So we asked what sort of content you want to make to have us include in that online community. How do you want to interact? What sort of a format you want? So we got all their feedback, and based on that, we created an online community. It was a moderated, closed online community. So once the community was established, we sent out invitations through hearing clinics to people, inviting people to take part in this online community. Once the participants joined the online community, they completed set of questionnaires about self-assessment of communication, quality of life, depression, anxiety, stress, social and emotional loneliness, and social support and interaction. So after that, they joined the community. We looked at their quantitative and qualitative data. So when we looked at the quantitative data, we saw that poor communication was correlated with both physical and mental health. Again, when we looked at the mental health scores, we saw that poor communication scores correlated with poor depression, anxiety, and stress scores. And again, poor communication scores correlated with emotional loneliness, but not with social loneliness. Then we compiled all the comments and posts made by participants and identified codes and themes and conducted the qualitative analysis. So these are some community content themes. They were about the challenges experienced, community engagement, connecting with others, coping strategies, empowerment. These are the themes we identify through this online community. For example, for an empowerment was, I always dreamed of being a pilot, but as an adult, I was told I couldn't do it because of my hearing was insufficient. When I was 29, I got my hearing tested for aviation standards and passed. So we came across a lot of comments like that in the online community, and we saw how each people supported each other, sharing their stories, giving them some suggestions, and really empowering each other. So we were really happy with the outcomes we got with the online community. As usual, we had some limitations. Not all participants completed the online questionnaire. Some had concerns about security concerns about Facebook. They said, oh no, I prefer to pick up the phone and talk to my family and friends. And we also saw that people in this particular age group had they were not very tech savvy or net savvy. So they wanted help. So came there at the end of the community group, the online community, they came up with some suggestions and said, if we could have a safe space for us to learn and practice with the support, and that would be helpful. So take-home message with work that we have done on mental well-being and psychosocial well-being of our research participants, and always look at the bigger picture. Treating hearing loss is really important using the suitable devices. However, communication, training, and support from peers also play an important role. So I'm moving into the next part of my presentation. That's about the frailty. This is an area which we recently started working on. I'm sure all of you know that if someone has one or more of these following symptoms, consider they could be at risk of frailty, that is unintentional weight loss, being exhausted all the time, weakness in grip strength, slow walking speed, and low physical activity. Hearing loss is considered an important marker in frailty. So this is a work done by one of my PhD students, Ron. She did a systematic review, and when we looked at about 4,500 manuscripts published over the past 10 years. The results revealed that there was a 73% increase in risk of physical frailty among the cross-sectional studies, and there was a 56% increase in risk and frailty among the longitudinal studies. So what we did was we went and looked at the data from our longitudinal study. In Western Australia, we do have a longitudinal study known as Health in Men study. So at the beginning of this study, there were 3,285 participants who were free of frailty. And we looked at their results for 17 years. 17 years later, we identified hearing loss as self-report hearing loss, or the records from the WA data linkage systems. And frailty was assessed using hospital frailty risk score. So at the end, 71% of the participants developed frailty over time. And we could conclude that there was a trend that men with hearing loss were more likely to develop frailty compared to their normal hearing peers. So the final part of my presentation about hearing loss and dementia. As you all know, every 3 seconds, someone in the world develops dementia. And currently, over 400,000 Australians do suffer from dementia, and it is considered the highest cause of mortality among Australians. With the Lancet Commission's report, we know that hearing loss is one of the highest modifiable risk factors for dementia. So a lot of people ask, how hearing loss lead to cognitive decline and increase the risk of dementia. There are many theories around it and hypotheses. One is when someone has a hearing loss, they have to keep on always trying to guess what is being said and trying to fill in the blanks. So that leads to increase in listening effort and increase the cognitive load. And we also know that when someone has hearing loss, that leads to changes in the auditory pathway and not auditory cortical areas. And we discussed before that hearing loss increases the risk of social isolation and depression. And there are common risk factors for both hearing loss and cognitive decline, including aging, diabetes, microvascular diseases, inflammation. So perhaps together, or maybe for some people, maybe one or two factors may be more important. So we believe that these other factors contribute to the increased risk of cognitive decline. So when it comes to hearing loss, there are two components. One is a peripheral hearing loss. The second part is the central auditory processing. According to the recent Lancet report, hearing loss contributes to 7% of the modifiable risk factors. According to the work which was done in Lin et al. In 2011, compared to those who are with normal hearing, those with mild hearing loss has 2 times the at risk of dementia, and those with severe hearing loss have 5 times risk for developing dementia. My team has done quite a lot of work on this area. We looked at the data from Health in Men study, which had about 37,000 old men. And we saw that untreated hearing loss increased the risk of dementia in this cohort. And then when we looked at the work which has been done about the hearing loss and dementia, and then we realized that most of the people have used test materials that contain a lot of verbal information to assess the cognitive functions of hearing impaired adults. For example, like the GMMSE or GPCOG or MOCA, not the MOCA for the hearing impaired version, the MOCA standard version. If you can't really hear the instructions, then you can't follow what's being said, then you tend to perform poorly, not because you didn't hear. So sometimes that can lead to people being misdiagnosed of having a cognitive impairment, or sometimes lead to overestimation or underestimation of their cognitive functions. Some of the work done by Taravne, that's another PhD student. We saw 4 central auditory processing scores in those with subjective memory complaints, mild cognitive impairment, and dementia. So central auditory processing is impaired in people diagnosed with Alzheimer's disease and its preclinical stages, and we will see these 4 central auditory processing scores many years before formal clinical diagnosis. So now talk about the solutions. What can we do as hearing clinicians, hearing researchers? What can we do? I think the first steps we wanted to find out what are the gaps in knowledge, attitudes, and practices of hearing healthcare professionals when it comes to supporting people with hearing impairment and dementia. Do we have suitable clinical assessment tools and rehabilitation tools? And what happens when we intervene clinically? So the first part, we conducted the survey with the Australian hearing healthcare professionals to assess their knowledge, attitude, and practices. And we found that 60% of the hearing healthcare professionals never received any training in administering cognitive screening, and 90% of them never conducted a cognitive screening. And 98% agreed that they should provide extra support. They need more time to provide, hearing aid, fitting hearing assessments for people with dementia. But 43 didn't know how to incorporate these cognitive support in hearing rehabilitation. 90% of the hearing healthcare professionals agreed that they should refer their clients with suspected memory problems to other healthcare professionals for further diagnosis. However, 73% didn't know about the referral pathways. And one of the comments came from these audiologists is that we don't know what to write in a letter to GP asking for a cognitive assessment. We don't know what to write. We don't know how to go about it. And some thought that that's kind of beyond their scope of practice. So when it comes to clinical assessment, if someone has dementia, only people with dementia, like less than around 50% of the people with dementia are capable of completing a hearing assessment and providing reliable responses. So it's important to incorporate objective hearing assessments when it comes to assessing hearing of people diagnosed with dementia. There are many objective tests. Recently, we received industry funding from Opticon to investigate the objective hearing tests that are suitable for dementia. So we are collaborating with Curtin University engineering team to come up with some objective hearing tests. Next, the cochlear implant programming. So cochlear implant recipients, they are long-term clients, because after we have seen in our clinical settings that after they go through the cochlear implant surgery and get their cochlear implant devices, they usually come for their annual assessments and annual programming, and sometimes a few more programming sessions to get their cochlear implant speech processor programmed according to the changes in their, they feel they need. So as clinicians, we rely on subjective responses given by our cochlear implant recipients to program these devices. So when we reach a point, if they are unable to provide us with reliable responses and we can't rely on their responses, we have to rely on other methods to give them a suitable map or a suitable program. So in this study, we looked at electrically step-reduced reflex threshold as a way to program these cochlear implants, and we've come to the conclusion that ESRD is a suitable method to program cochlear implant maps for those who are unable to provide reliable responses. Then we wanted to look at the clinical intervention, impact of clinical intervention on cognitive functions. So we looked at, we followed cochlear implant candidates and cochlear implant recipients for a year, and we compared the results of cochlear implant recipients with that of candidates, those who are waiting to receive a cochlear implant device. And we saw that after receiving a cochlear implant, 12 months of receiving a cochlear implant, we saw a significant improvement in speech perception in quiet scores of those cochlear implant recipients. And at the same time, we saw an improvement in some of their cognitive functions like attention set switching, reaction time, and spatial working memory tasks. Then the next question was, what happens when we treat hearing loss using hearing aids? I'm sure all of you must have heard about the ACHIEVE trial in the US. In ACHIEVE trial, they looked at the impact of hearing aids on those who have normal cognitive functions. They did have a small cohort who were higher risk for dementia, but in our trial, we only focused on those who were at risk of dementia. So primary aim was to investigate whether hearing aids decreases the 24-month rate of cognitive decline in participants who were diagnosed with mild cognitive impairment. Secondary aims were to look at their executive memory and executive functions, mental well-being, quality of life, physical health, and health-related costs. So we went to the community and recruited 180 participants. We've just finished our data collection, and now we have an interesting phase of analyzing the results and finding out what happened. So we looked at their global cognitive abilities, nonverbal cognitive assessment scores, and also general physical and mental health scores as part of the study. We also looked at their MRI and FDG PET scores, and are currently in the processing of getting data from the data linkage to look at the health economic impact of the study. 50% of the participants were fitted with the hearing aids. The other group was a delayed control group. We fitted them with hearing aids a year later. So I don't know the results yet, but I'm really interested in finding out the outcomes of this study, and hopefully within the next few months, we'll be able to share our findings with them. So this is my last slide, and I would like to, because I come from a clinical background, I'd like to emphasize on the implications, clinical implications of the work that we do. In clinical appointments, it's really important to emphasize the importance of attending the appointments with family members or caregivers, and get these family members or caregivers involved in the appointment, get their feedback on hearing difficulties, use formal or informal assessments to find out information. And I'm not sure whether you all have seen, especially cochlear implants switch on. These patients receive a lot of information. Most of them are information given verbally, or then they have to go online and figure things out. So we are recommending to manufacturers that they kind of need to rethink about the aging population and make some changes that are suitable for them. So when it comes to devices, it's important to consider devices that are easy to use with simple controls and provide instructions in print. If you have seen hearing aids, we need to change the batteries, and these hearing aids are really, really small. And changing batteries, it's quite a challenging task for old adults, especially if they have arthritis in their fingers. So discuss about the rechargeable options. And then talk about leaving these devices in a spot of regular activity, set reminders, or give them we have seen they're giving people with a brightly colored case that seems to help them identifying where their devices are. And it's also important, the next step for us to train our audiologists about the communication strategies for acknowledging audio dementia, and informing the GPs about the changes that they observe in clinical settings, and ask for formal assessments that are suitable for hearing loss. So with that, my presentation comes to an end. Today we covered several topics related to hearing loss and its impact on old adults. I hope that the points that we discussed during this presentation would help all of you when you're supporting old adults in clinical settings. So if you have any questions or would like to be part of the work that we do, here are my contact details. Please feel free to get in touch with me. If you have any questions, I would like to answer them. Thank you for listening.
Terrific. Thank you so much, Donna, for that a bit of a tour de force, I think, of the amazing work that you and your team have been doing over the last almost decade. We do have several questions. Tanya asks, is there not some confounding going on, given that increased age is significantly linked to both increased frailty and increased hearing loss?
Bianca, would you mind repeating the question, please?
Sure. Tanya asks, is there not some confounding going on, given that increased age is significantly linked to both increased frailty and increased hearing loss?
Possible. But what we have seen that with increased aging, with increased hearing loss, we have seen an association between all the other factors related to mental well-being, and they are all together connected with frailty as well. So we, in our studies, we do control for all of these factors when we are trying to see the association between hearing loss and frailty. After controlling these confounding factors, we have seen an association between hearing loss and frailty.
Great. Thank you so much for that, Donna. We've got another question slash comment from Natasha. It's quite a long one, but it's also in the chat, so you can see it there too. Natasha writes that with digital equity, can we look at older people's access to digital tech and data, Wi-Fi, etc., rather than focusing on their age as a barrier to digital literacy? Research in New Zealand by the Citizens Advice Bureau and others shows that digital barriers are often equity-based. That is, lower income, young and older people may not be able to afford, hang on, I've got a big box in the middle, may not be able to afford smartphones and data plans. Maybe socioeconomic support could help people join online peer support communities.
I think that's a really good question. So the group that we studied were 60 years and above. So when we looked at the barriers in particular group, and they all came from I would say better economic backgrounds. They were retired. They were living in a good community supported aged care settings, or in the community. So when we looked at the barriers for them, there was some concerns about. I think it was also the comfort zone. They were comfortable in reaching out their friends, having a conversation, picking up the phone, and that was also a preference. And there were a lot of concerns about using, I would say, social media for connections. That was not their comfort zone. And you raised a good point about the digital literacy. I think we need to start there with this particular group. However, I come from Sri Lanka, so I can talk about the people who come from lower income backgrounds. Yes, I have seen a lot of people, they can't afford smartphones, they can't afford data plans. And in that context, yes, it's more than age. The economic background is a barrier in that context. And I think also we have to talk about the different cultures as well. Certain cultures where people would like to do things more, there's more community connection. And in some cultures, we see they're more independent. So I think there are several factors come into the play here. But when the study that I talked about, the age was a barrier in that particular study.
Great, thanks, Donna. You've got lots, I think, of comments and questions coming through. We've got another one here from David Williams, who says, or who writes, we provide guidance for people to more effectively plan their longevity. What simple steps would you recommend to a person to at least begin to understand the possible impact of hearing loss on health longevity, and what preventive actions could they take to minimize the impact?
I think the first step is the awareness. We have done huge amount of public health seminars, and we've used YouTube and radio interviews and a lot of newspaper articles to talk about importance of the taking care of your hearing health, because we come from a hearing background. Our first step is to, if you are struggling to hear, if you think that you need to increase the volume of your TV, and if your family members have to, repeat things that they're saying. You feel you're struggling to hear. First thing is to get the hearing test. It's not a very challenging thing. It's a very non-invasive. You go to a qualified audiologist. They will put some headphones on you, give you some pure tones or the beeps. Listen to what you say, and then you will say whether you can hear the beeps or not. And that's a very simple step. And that will tell you where the challenges are. And for some people, it's just a simple things like having some communication training around. Some people would benefit from hearing devices. So then the next step would be to have that conversations with their healthcare provider or hearing healthcare provider about the suitable steps to take. So I think the first step is awareness. First step would be just to get a hearing test.
Great. Thank you very much for that, Donna. I've got one question, maybe, and we can close the session after that. So there are a lot of barriers to the uptake of hearing aids. I wonder if you could elaborate on some of those barriers and perhaps even comment on a community stigma around using hearing aids.
It's a really nice question, Bianca. When it comes to hearing aids, people have a lot of stigma around it. They associate getting hearing aids with aging. So there are several barriers, and some people do benefit from getting support from the government-assisted hearing service program. So some people can't really afford. As a highly technically, I think some of the hearing aids come from with a lot of advanced technology. Some people really can't afford that. And even sometimes people do get their suitable hearing aids, they just leave it in their drawers rather than using it. I think there's a challenge of us educating the people that just because you get a hearing aid, you're not going to next day magically start hearing everything. You need to retrain your brain to hear the sounds, hear the speech. And we always tell people, listen to the radio, talk to people, because what you hear through the hearing aids is slightly acoustically modified signal, which is a new signal actually. So you need to retrain your brain to get the best benefit out of it. But people think, oh, I got my hearing aids, I'm okay one-to-one. When I'm going out, I just struggle in group situations, so I'm going to wear the hearing aids then. But that doesn't happen. You need to wear your devices more frequently and use them, talk to people, listen to things, and that's when you're going to get the best benefit. I think that message we need to share with people.
Terrific. Thank you so much, Donna, for that. I think Fiona has also made a comment in the chat, and she says some of the barriers that she often hears about from the community relate to cost, comfort of the aid, vision impairment, and dexterity impairment, making them challenging to use and a sensory overload. And David's got, okay, David, we're going to give you the last question, and then I really will close the session. Is how do you identify an audiologist who is not product connected?
Before I answer David's question, I have to say, Fiona, you are very well informed. These are the challenges people have when it comes to using devices. Perhaps we could have a conversation, given the interest of time, we could have this conversation offline. David, all I say is when you look for an audiologist, you look for the qualifications and look for someone who is a member of Audiology Australia or member of College of Audiology, and that this person who's gone through the necessary training, necessary experience, and accredited audiologist. So I would look for those things, qualification and associated with Audiology Australia.
Okay, thanks for that, Donna. I think we've well and truly put Donna through her paces with several questions on different topics. I think if you wouldn't mind, please join me in thanking Donna with your clap reactions. I think it's an amazing body of work that she and her team have been leading over many years. So well done to you, Donna. Thank you so much for your talk today. Next month, we're going to have Professor Alison Mudge joining us, and she will be presenting on improving hospital care for older people. We will be hosting that talk on the Tuesday, the 17th of September at 12 p.m. And with that, I will close today's session. And thank you very much for joining us. Good afternoon.